السلام عليكم يا دكاترة. Today we are talking about the surgical causes of non-bilious vomiting in the infant age group. Embryologically, the esophagus and trachea arise from the foregut. They start as single tube. Then the lateral tracheoesophageal folds starts to move from lateral sides till they meet in the center, separating the foregut to anteriorly, forming the trachea, and posteriorly forming the esophagus. If there is a defect in this movement, sometimes there is defect in the movement of the lateral tracheoesophageal folds, leading to incomplete separation and a fistulous tract between the trachea and esophagus, and sometimes forming an obstruction in the esophagus, leading to esophageal atresia associated with or without tracheoesophageal fistula. Assalamu alaikum ya dafatra. Today we are talking about the surgical causes of non-bilious vomiting in the infant. Clinically, there will be choking and coughing and cyanosis due to retention of the saliva in the upper esophageal pouch, blind pouch, and spillage of the saliva inside the respiratory tract. After delivery, the neonatologist try to pass a suction catheter through the esophagus till reaching the stomach. If he failed to pass this tube, this will raise the suspicion of esophageal atresia. Arrest of the bile in the upper esophageal pouch would be a diagnostic sign for esophageal atresia. Routinely, we don't perform an upper esophagogram for diagnosis, and we need this only in selected query cases. And if we perform this test, you must aspirate all the injected contrast after visualizing the pouch for fear of aspiration. In the first X-ray, you can see the stomach bubble aeration. So this case has tracheoesophageal fistula with the esophageal atresia as well. But the X-ray in the middle, you found an absent aeration in the stomach or in the abdomen, because it's pure esophageal atresia without fistula. We have 5 types of esophageal atresia with or without tracheoesophageal fistula. Type A, it's a pure esophageal atresia without any connection between the esophagus and the respiratory tract. Type B, there is a fistula between the upper pouch and the trachea. And type C, which is the most common type, there is a distal fistula, which is a communication between the lower esophageal pouch and the trachea, usually at the level of the carina. And type D, there is 2 fistulas, one between the upper pouch and the trachea, and another one between the lower pouch and the trachea. And type E, there is a fistula without atresia, which is called H-shaped fistula. And type F, it is esophageal stenosis, congenital esophageal stenosis and narrowing without tracheoesophageal fistula. Waterson Classification is for the risk assessment of our cases of tracheoesophageal fistula, and determine the prognosis of our cases, with category E with the best prognosis, average weight, and category B with the fair prognosis, less weight and some associated anomalies, and minor cardiac anomalies, and the worst prognosis in type C, which is carrying the small birth weight or severe congenital, especially cardiac anomalies. The main goal of our surgical treatment for these cases is restore the continuity of the upper and lower esophageal pouch by doing a primary esophageal anastomosis and transfixation and ligation of the tracheoesophageal fistula if present. Delayed anastomosis, usually we perform the anastomosis in a delayed fashion after if there is a long gap between the upper and the lower pouch, and in the cases unfit for surgery or there is major cardiac anomalies, need supportive and resuscitation before the intervention. For preoperative preparation, the patient will be admitted in the neonatal intensive care unit, receiving IV fluids and antibiotics. We put some suction tube in the upper esophageal pouch and continuous suction to drain the saliva and decrease the risk of aspiration. Sometimes if there is tracheoesophageal fistula and if there is a distension of the stomach and the baby is still unfit for the operation, we do the gastrostomy under local anesthesia to decompress the stomach, and this in cases of tracheoesophageal fistula and respiratory complications, and the baby still is not fit for surgery. As shown here, the baby will be put in the lateral position, and the incision will be in the posterolateral part of the chest, because the esophagus and the trachea are contents of the posterior mediastinum. So to attack the posterior mediastinal structures, your incision should be in the posterolateral part of the chest, at the level of the fourth intercostal space. As shown here in this diagram, we the first step in our operation is to attack the esophageal fistula, which usually between the distal esophagus and the trachea at the level of the carina. We ligate the fistula and divide this fistula and check if there is air leak after suturing it, and then we start to mobilize the upper and the lower pouch to do the anastomosis between the upper and the lower pouch after passing the rail from the mouth of the baby, from the nose of the baby till reaching the stomach. The most common complications of after repair of tracheoesophageal fistula is the gastro-esophageal reflux. In third of cases, there is an association of gastro-esophageal reflux, and also due to mobilization of the lower pouch, this sometimes affect the esophagogastric sphincter and esophagogastric junction. Also, tracheomalacia is associated with tracheoesophageal fistula, and this will lead to aspiration and stridor postoperative. Also, sometimes we get strictures at the site of the anastomosis, and these strictures needs sessions of endoscopic dilatation. And the gastroesophageal reflux usually can be managed by a medical treatment and the proton pump inhibitor, and if there is no response, sometimes we need to do anti-reflux surgery as Nissen fundoplication. The most important symptom is the forceful projectile non-bilious vomiting after every fit, and the baby is still hungry and needs more feed. The most important is to correct the metabolic abnormalities before operation, is to correct the metabolic alkalosis and to correct the hypokalemia. If you manage to feel the thickened pylorus by examination, palpation of the abdomen, if you manage to feel the olive green sign, then it's pathognomonic for pyloric hypertrophic pyloric stenosis, and then you will not need to do pelvic abdominal ultrasound. In ultrasound, the most important thing to measure is the pyloric canal length, which is abnormal if it is more than 14 millimeter, and pyloric canal split thickness, which is abnormal if it is more than 4 millimeters. If the ultrasound is not conclusive, then you will need to perform upper GI series. After correction of acid and electrolyte imbalance, the surgical technique is called Rumstead pyloromyotomy, by incising the thickened pylorus till reaching the bulging mucosa. There are some physiological factors to prevent the reflux. The anatomic factors are mainly the length of the lower esophageal sphincter, the intra-abdominal part of the esophagus, which is 2 to 3 centimeters intra-abdominal, and the acute gastro-esophageal angle, and the phreno-esophageal membranes at the esophageal hiatus, and also the physiologic factors like the effective propulsive peristalsis, pushing the esophageal contents, food and saliva downwards. So the indication for surgical intervention to treat gastroesophageal reflux in children, if there is failure of medical treatment for periods like varying from 6 weeks to 6 months, or if there is severe esophagitis causing hematemesis, or if there is persistent vomiting and failure to thrive not resolved with medical treatment, or there is respiratory symptoms affecting life and threatening life, like aspiration and apnea during sleep, and choking. So those are solid indications for surgical intervention. The most common operation to treat reflux children is Nissen fundoplication, by performing a wrap from the fundus of the stomach around the intra-abdominal esophagus to act as a sphincter, artificial sphincter, during distension of the stomach, circulating around the intra-abdominal esophagus, preventing the reflux.